Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending our session 2 of the Learning Collaborative Improving Public Housing Health Center Services Delivery through Cultural Competence and Health Literacy. The National Center for Health and Public Housing receives funding from HRSA to provide training and technical assistance to community health centers across the nation, and specifically to those located in or immediately accessible to public housing. So thank you so much for attending this activity. We are live, so at this moment our lines are muted. If you have any questions or if you have anything to ask, you can either use the raise hand icon. Your line will be unmuted, or you can use the chat box, type your questions, and then we are going to respond live to your questions. At the end of the webinar, we are going to have a Q&A session. So if you have any questions for the presenter, please save your questions and ask the questions at the end of his presentation. There are around 385 community health centers located in or immediately accessible to public housing. And according to UDS data, they serve around 4.4 million patients in 2018. There are 107 public housing primary care grantees, and they serve over 800,000 patients in 2018. So it's my pleasure to introduce Dr. Levine Rios. Dr. Rios is a native of Puerto Rico. He is a social scientist and educator that has worked in the fields of education, public health, and organizational development for over 3 decades. As both a practitioner and researcher, his formative background includes 6 earned degrees from Harvard University, UC Berkeley, University of Illinois, among other universities, as well as a postdoctoral studies at the University of Michigan and Oxford University. He was editor-in-chief and co-founder of 2 Hispanic journals on social research, as well as author of more than 50 articles and manuscripts, and more recently a book, The Story of Latinos and Education in American History, published by Peter Lamb Publication in New York City. As a social scientist, his work experience has been vast, having worked at the state level in public health and with the federal government in education, then subsequently directing research initiatives in various domains in the nonprofit and cooperative sectors in both the US and abroad, with extensive focus on Latino issues together with expertise on cultural competence in the delivery of education programs and public health services. Once again, thank you so much, Dr. Novoa Rios, and good afternoon.
Thank you. Thank you. There's a lot to cover this afternoon, but let me be very brief in terms of an introduction to the topic and how to improve health literacy among vulnerable populations. We're going to address health literacy from several vantage points today. The first is to well understand the concept of health literacy and all that it implies, as we have learned from the CDC perspective, as well as from evidence-based research the past 10 years. The second is to know what to do about health literacy. That is the translation, or what I like to say, the transliteration of health literacy into patient action. Learning from the patient's perspective is critical to the process. Here we will emphasize how to get patients to act on the best health knowledge available. Then we will end by bringing into view another perspective of the health literacy dichotomy, as I call it. That is the perspective of literacy from the provider's point of view. Providers need to be highly literate to guide the process. As an example, we will zoom in on what is occurring today or not with the COVID-19 pandemic. So what does all this mean? Basically, it means we will not enter into reviewing useful toolkits on health literacy for today, but we'll cover this topic in our next webinar. Toolkits have been usurped by the issues on the COVID-19 epidemic, which is a very important topic in the context of health literacy for today. But before we begin, let's start with 3 probing questions. And these are in front of you. I will read them out and we'll have about 30 seconds of a break for you to respond, and then we will collect your responses and read them out. The first, and they're all true false on health literacy. The first is patient knowledge about health literacy is primarily about health information. True or false? Secondly, health literacy is mostly related to reading literacy. True or false? And finally, how we communicate about health is just as important as what we communicate. Again, true, false. Let's take about 30 seconds and review your responses very soon.
All right, so for the first question, we have patient knowledge about health literacy is primarily about health information. True or false? Okay, second question, health literacy is mostly related to reading literacy. True or false? And the third question, how we communicate about health is just as important as what we communicate. True or false? Okay, so the responses were for question number 1, 100% said true. Question number 2, 100% said false. And question number 3, 100% said true.
Okay, thank you. Let's quickly review. And the first one, patient knowledge about health literacy is primarily about health information. Technically, that's part of the equation, but not fully. And I would have to add to that, understanding, not just knowing, but understanding is critically important, as action is also critically important. So though the statement may be accurate, it is not the full picture. For number 2, health literacy is mostly related to reading literacy. 100% said false, and that is very, very accurate. There's much more to health literacy than reading literacy, which we will be talking about soon. Thirdly, how we communicate about health is just as important as what we communicate. Again, this happens to be true, and we had 100% response to that as fully accurate. These are two sides of the equation. Either both are equally important in the process. Thank you for that. Now, in talking about health literacy, everyone benefits from health literacy: the patient, clinical staff, provider agencies, community and society, as does the overall economy. And when we talk about health literacy, what is it that we mean by the term? During the last webinar, we talked a little bit about this definition, and let's just quickly review. Health literacy is the degree to which individuals have the capacity to 1, obtain, 2, process, 3, understand basic health information, and foremost, number 4, take appropriate action for healthy decision making. Now, in that process, we need to understand that there are two particular populations, certainly much more, but two in particular that we should highlight, and that is that about 80% of seniors have low levels of health literacy, according to the recent literature. And about 90% of English language learners, known as ELLs, also have low health literacy. So unquestionably, the area of literacy in reading and numeracy in education continues to be related to health literacy as it affects health literacy in general. But as we have seen, it's not the only determiner. But let's quickly review, for example, some of the data on reading and numeracy. At the turn of the century, in 2005, the Education Department reported that there had been little progress in American literacy from the previous decade, which was a bit of a surprise entering this new century. As then reported, while some racial groups were improving slightly, as were non-racial groups, as white America, this was not the case for the Latino population, which had decreased in literacy. That is, the population was unable to use a TV guide, for example, to find out what programs were being aired on a specific time period. And in numeracy, they had difficulty comparing prices for food purchases, such as different cuts of meat by weight or liquids by ounces and their relative costs. So overall, about 14% of the US population, 32 million, have low reading and numeracy skills. However, Latinos in particular have lower levels of literacy compared to average American adults, 44% versus 14%. And in 2013, the US ranked lower than 15 of 22 OECD countries worldwide in an international literacy test called the PHPC test. So that's interesting basic information in terms of health literacy. Generally, adult literacy versus health literacy creates a bit of a gap in terms of the differences here. For example, while adult literacy hovers around 14%, current estimates are that 9 in 10 adults lack the skills to fully manage their health care and prevent disease. That is a far cry, almost a flip-flop difference between the two, which tells us that low health literacy is considerably higher than general adult literacy and numeracy in this country. Now, we know that low health literacy is linked to particular determiners of health nationwide, poor health outcomes in general, greater likelihood to misread prescription labels, increased hospitalization rates and visits to emergency rooms, less use of preventive care, lower prescription and health plan adherence, and eventually leading to higher mortality rates. So why is it that we continue to fail in communicating about health? For one, we're learning that health literacy is more than general literacy, as we have stated. But for another, we have also learned that it is more than mere information diffusion, such as passing out brochures to patients and assuming those brochures are sufficient information for the patient. Instead, it is more about a two-way communication process. In fact, health literacy is a process of sound communication and relationship between patient and provider. It is about patients having a role in letting providers know about their concerns and sharing their questions, as well as providers having a role in building trusting relationships with patients that deliver messages in ways that patients can understand and feel comfortable to ask questions without embarrassment. In this process, in this encounter, patients are interested in asking three major questions for the most part from all that we have reviewed in the literature. And these are, what is my main problem? What do I need to know? And why is this important to me? Now, as providers, we do not always know which patients have limited health literacy. So, in that process, providers must check for understanding by using health literacy strategies. This is key to the entire process of dialoguing and communicating. Now, let me give you an example of health nutrition that can be gathered from something as simple as a food label or a nutritional label that comes with packages of food, because such information can be used as an indicator of literacy, sometimes even an indicator that is related to health literacy assessment. For example, if we take a label, let me go back for 1 second. Health literacy is not just about reading, but about understanding. It requires patients to process information to get to the right conclusion, and for patients to act on this information to take care of themselves. Sorry, back to the nutritional questions. From an ice cream label, as we see the label here on the left-hand side, there is sufficient information about the contents of this particular carton of ice cream. And if I was to ask 4 basic questions from that label, let's take each of them in terms of its context. Number 1, if we were to eat the entire container, how many calories would we consume? That's straightforward in terms of 1 serving being 180 calories, as we can see. Now, secondly, if one is allowed to eat 60 grams of carbohydrates, how many servings of ice cream does one have? Now, that question is a little bit more difficult, as it requires some minimal math to get to the answer. And it also requires an understanding of what we mean by the term carbohydrates, even though it does appear on the label. So the amount of literacy here is a little bit higher, as it also combines with numeracy. Example number 3, if you ate 2,500 calories per day, what percent of your daily calorie intake would you eat if you had only 1 serving of ice cream. Again, calculation is needed to determine that answer. Now, number 4, if you were to reduce sodium intake, would this be a good source of nutrition? Now, that depends on how much sodium intake is healthy, or in some cases, if one has to reduce salt intake, as a diabetic patient would have to, then it involves a calculation that 1 serving is 85 milligrams of sodium versus the total number of milligrams one should intake in a given day. So these are indicators of a certain level of literacy, not terribly different from what takes place when we examine a bottle of pills, typical medication. In some respects, this is not different from reading an ice cream label. In other respects, it is, but let's take it 1 step at a time. In this particular bottle that we see, hopefully you can read everything in the bottle. You should be able to. These are questions a patient can answer from the prescription bottle, possibly. 1, how many pills can this patient take daily? In this case, it's 2 pills 3 times a day. Number 2, at what time of the day should the patient be taking pills? Now, this question is not indicated in the instructions on the label. This has to come from somewhere else, likely the provider. Now, normally it's assumed that if it's 3 times a day, it's going to be at each of 3 meal times. Not necessarily the case, and a lot depends on the patient's normal eating habits. So that should be checked and not necessarily assumed. 3, for how long a period of time can these pills be taken? Now, this is a question that makes the assumption that if you were to have 6 pills a day, and you see that the total quantity there at the bottom is 30 pills in total, then it's 30 divided by 6, or it's 5 days in duration. However, question number 4, must the patient take pills all the time? If you go back to the label, it says 3 times daily as needed. Well, what do we mean by as needed? Obviously, then it's not all the time, and maybe not even every day. And again, this information, although it is in the label, is an inferred piece of information that has to come from extraneous sources. Again, the provider or the physician. Finally, can the prescription be refilled? According to the label on the bottle, no, there are no refills for this particular prescription. Now, let's take this a little bit further, because patients may want to also have additional questions, but how are they going to get this information? For example, should the patient be taking this medication before or after a meal? Very important for a certain medication. Can this medication be taken without liquids? Now, this may sound rare, but lots of patients just pop a pill even without any liquids whatsoever. Does it matter if the medication is taken with water, as different from drinking it with coffee or juice? Again, patients need to know that certain medications should be taken with water only, because coffee or juice can alter the impact or the effect of the medication upon ingestion. So again, this information needs to be known but it cannot be contained in the instructions on the bottle. This must come from the provider. What are some of the side effects to the medication? We don't know unless we look it up in the PDR, and who has the PDR, or we look it up in the internet. It's important for the provider to also talk about the side effects. And as a result, maybe stop taking the medication at a certain point. But then again, what happens if the patient stops taking the medication without consultation with the doctor? In some cases, and in some instances, this can be highly dangerous. So these, and we can go on in terms of other questions that are additional, but again, every prescription, for example, needs to be qualified by the provider for the patient and never assumed. So how can the provider dialogue with patients, or how best to dialogue with patients? And that brings us to practical strategies that providers should use. And we're using 7 practical strategies because we wanted to limit it to the most important strategies that we find in most of the toolkits and most of the information that's going out currently in public health. One of them is to look for clues regarding non-adherence. So the provider is using clues in terms of relating to the patient, or in terms of understanding the context of the patient. For example, if there are a series of missed appointments, if the patient is not taking medication appropriately, if the patient has not completed or refuses to complete or does not want to complete medical forms, these are all clues that are contextual that providers should be paying critical attention to. At the same time, there are questions that may come up in the dialogue with patients that providers should keep in mind and know how to expand the dialogue. For example, I forgot my glasses. Can you read this to me? That kind of question is a cry for help. For one, the patient may be able to read, but the patient may be asking for additional help. That's a major contextual clue. Another may be, I got confused about my medicine, so I didn't take it. Now, that could be an excuse, but it can also be an opportunity for the physician to review what the confusion may be about taking that medication, because it could be a true case of confusion, as it can also be an excuse. And again, that has to be filtered with the patient. Another area is using AV-AIDS models, illustrations, instead of words. And I can bring a personal example to that myself. I have a major crick, as I call it, on my neck, where my neck now is forcing a little bit of a problem with my posture. And I have not understood very well what is causing it, even though I have a curvature of the upper portion of my spine. And it wasn't until I was able to see a particular chiropractor who happened to have the skeleton of a spine in the office, where I was able to manipulate the skeleton and see exactly what was occurring in my spine. And only then could I fully understand how it was that although the problem was in the neck, I was getting referral pain in my leg. And I didn't quite get that association until I started playing with that particular spinal model that the doctor shared with me. So again, and I should know better, I knew there was a relationship, but I did not understand the relationship until I played around with the model. Now, that's a far cry from what we expect from most encounters, but again, it was an illustration to me tactily that there was a problem, and it helped me fully understand what was going on with my own spinal difficulty. Third area of a strategy is using demonstration. Now here, for example, a physician or a PA could show the bottle of pills with the label and walk through the process as we did with a series of questions and dialogue with the patient. Here, number 4 is highlight or circle important points from a handout, as information that is presented is not always clear. Print information, it may not always be clear, or a page may have too many words and a patient may miss certain points that are critically important, if not highlighted. I remember for myself talking about my problem with my back, my spine, that I was given a handout. It was a very useful handout of a series of exercises. I think it was about 5 exercises that I should be doing daily to correct some of the pain or to minimize some of the pain that I was having. Now, these exercises seem rather straightforward. They seem rather obvious. I took the 2 pages home and started doing the exercises, but I wasn't quite getting the full benefit. And after several days, I happened to bump into at a grocery store a friend of mine who I had forgotten was a physical therapist. And in sharing this information, it was interesting. The physical therapist literally went to my home and showed me how those exercises should be conducted, how they should be performed. And it was considerably different from my interpretation in seeing good, logical illustrations of the exercise on a piece of paper. So again, there are ways in which we can maximize information that is provided to us in handouts or in other ways that may need additional information or may need additional help. Using plain language, speaking slowly, avoiding jargon, keeping away from acronyms is also very important. For example, certain terms. We talked about carbohydrates before. The term hypertension is one that is highly misunderstood. We know what hyper means, we know what tension means, but when we put the two together, hypertension is vastly different from either of the other two. And so the composite of multiple words into one can be a little bit difficult to fully understand. And so these terms need to be defined. They need to be clarified. Checking for understanding by touching base with the patient is extremely important. And this is a way that a doctor or physician's assistant or nurse can come back and dialogue with the patient to clarify information. Let me give you an example. Years ago, I was dealing with a particular patient, and it came into a rather difficult situation because the patient had just been informed of a critical illness that she had, and was to share that in that evening with her family, but specifically with her husband. And we noticed that she was rather nervous about it and not quite sure how to explain, how to articulate it to her husband. So we said to her, Carmencita, let's role play the process. Share with us how it is that you might articulate this or express this new illness or this new diagnosis to your husband tonight. And so in the process of her verbalizing this orally to us, we noticed that there was a little bit of misinformation or not full understanding that needed clarity in terms of what she understood from what it was that we had just shared with her. So in checking for that understanding, we were able to clarify some misconceptions from a discussion we had just had with her within less than an hour. So checking for understanding by role playing of that type, among other ways in which that can be done, can be extremely, extremely helpful. And this one, number 7, referencing local sources, is very helpful because it encourages patients to self-navigate their care. 95% of their time is going to be outside of a clinic. And so they need to navigate their care from their surrounding, but hopefully advancing that surrounding beyond just their social or family circle. And here's where a provider can be of a lot of help if they know the environment, they know the community, where they can say, hey, Carmencita, next week, you may be interested to know that there is an event at your local community agency, ABC, not too far from where you live, just several blocks away from your home, as we understand it, where they're going to be having some demonstrations of relaxation exercises at no cost at this community center. This may be helpful to you. You may want to join. Or, Carmencita, did you know that next week on WJJD radio, there's going to be a presentation on the ABCs of diabetes that we think could be very helpful for you to listen to. And it's going to be aired at different times in different languages. So that may be something that you may want to listen to, and we'll provide the information to you, et cetera, et cetera. The idea is to get the patient into a new routine and to take advantage, to avail themselves of local resources that may be available. In a nutshell, these are multiple strategies that providers should use, and we've just indicated a number of them that we have found to be very, very helpful. So, going back to health literacy, let me suggest the following formula, or the model, which I call the ACA model, that leads to, which is that arrow, leads to action on the part of the patient. And ACA means the first A for access, and that is access to information. But it's not just mere access to information, it is also understanding the type of information that is being delivered or is being read or is being presented, and the source of information. Who is making this presentation? Where is this information coming from? And so forth. Access and quality of access is extremely important in the model toward behavioral change. The C represents comprehension. That is, does the patient understand the information? Or better yet, how well does the patient understand the information? And the next letter A, once again, is acceptance. And this is critically important. And this we find to be really, really key to this formula in terms of understanding or knowing if the patient can or is willing to integrate new information into their schema of understanding, into their world framework or their cultural framework. Is it acceptable? I remember years ago, I was working with a team in the South Pacific Islands, and this was on substance abuse. And we came across a community that was using betel nut quite extensively, and realized that several individuals in that community were having adverse effects to betel nut. And this was a cultural process. This was a habit inculcated into that particular community, and one that was not easy to break. So the question was, in the context of culture, how do you change behavior in this kind of a context? Not easy, but even though individuals, most community members knew that too much betel nut could have adverse effects, it was difficult to break the habit, or it was not socially acceptable to break the habit. So that acceptance was major within that context. And we can give other illustrations of that. One that comes a lot in the US is, if we think back, not long ago, when it was realized that smoking was dangerous for your health, and smoking cessation programs were having much difficulty in changing behavior, not because of the knowledge that smoking was bad, but because behavior was hard to change and many times unacceptable to change. So the acceptance of that was critical in the model of action or reaction or non-action in terms of that particular context. So what is missing for that model for behavioral change or for action in terms of a more socially desirable behavior is, what is it that motivates an individual, a patient, a consumer to change? What is missing from the model? And what we say is that there needs to be a driving motivation, such as a reason or a purpose, for the patient to act on their best interest. What is the trigger here? What is the motivator here for the patient to change and take action? Why? The patient must be vested in the process. How? The patient must be engaged, involved, interested, enthused about taking care of themselves. The result? The patient must view their health as a personal goal and an important challenge for a higher quality of life for themselves or even for their family. And again, the model by itself, without that motivator, is not sufficient for behavioral change. Okay, we've made our point in terms of a model, and we have reviewed some of the ABCs of things that providers can do, as well as understanding health literacy from a set of perspectives that should be helpful. Now we're going to change a little bit the conversation, the topic, into another sphere. And in doing so, let's take a quick break and respond to 2 more questions regarding health literacy. And again, there are 2 false questions that are in front of you. And because I read the questions out before and Fida also read the questions, let me not read them this time around and have her read the questions as she takes the polling from you in terms of your responses. And again, we're going to be waiting for 30 seconds or so in terms of this process. So I'll turn it over to Fida in terms of this process here on.
All right, thank you so much, Abdeen. So I'm gonna go ahead and pull up question number 1. So question number 1 says, health literacy is primarily about getting patients to act on their health knowledge. True or false? Oh, yes or no? All right, and question number 2. Health literacy greatly also relates to what is going on regarding our current COVID-19 pandemic. True or false? Okay, so the responses were for question number 1, 100% said false or no, and number 2, 100% said true.
Excellent, thank you. Health literacy is primarily about getting patients to act on their knowledge. And so, yes, it is false in that knowledge does not necessarily lead to action. And so the question is it appropriate health knowledge here? Not just general knowledge, but is it appropriate health knowledge from the perspective of public health, not just the perspective of the individual patient? Number 2, health literacy is greatly related to what's going on regarding our current COVID-19 pandemic. And so that is very true. And we'll now focus a little bit more on that particular topic. And in so doing, there are 2 levels of health literacy that are important to understand. It's almost a dichotomous situation. The individual level, which is what we've been talking about. But the second is the societal or community level at a broader scale. Remember last time we were talking about cultural competence being at 2 levels, one being the individual level, but the other being the organizational level. In a parallel way, when we talk about health literacy, we're talking about the same kind of difference, same kind of dichotomy. And what we are learning from what is occurring via the current pandemic is considerable. Among them is understanding that health and its consequences are affecting all levels of society: employment, income, social engagement, economy, etc. We're also learning that leaders can enact policy, but it doesn't mean people will follow. We also learn that high respect and acceptance is afforded to officials that can communicate clear, sound, consistent policy in terms of gaining greater public confidence in general. We are also learning that we must be cautious regarding mixed messaging and misinformation. One example is the myth that occurred that African Americans, Blacks, were exempt from COVID-19 infection, which was damaging long-term to African Americans and already exacerbating difficult conditions. We also have been learning rather recently, more so the last week and a half, that highly vulnerable populations are always prone to higher rates of mortality during the pandemic. And this includes the following vulnerable population sectors: incarcerated populations, which includes not just the jails and prisons and detention centers, but immigrant shelters, nursing homes, the homeless, residents of low-income housing, senior citizens, persons with pre-existing conditions, and racial minorities. So overall, learning has been that health literacy for the system goes far beyond any individual level of health understanding or health literacy per se, as it also becomes a systemic issue across the entire population. So health literacy must also reside at the provider and broader community level. Major conclusion here is that literacy at the wider system of health provision and leadership represents another level of literacy, or a different level of literacy beyond individual knowledge. This is systemic in nature and is about health action for the broader population and its consequent risks to overall society. It operates at the community level and affects all population sectors. Major statement at the bottom here is, for the well-being of the nation, it is imperative to promote such health literacy at the highest levels of government. And so, in a nutshell, and I'm going to be very conscious of the time frame, during times of health crisis, such as pandemics, other than medical staff and first responders, firefighters, the police, there are the persons that represent janitorial sanitation workers, as an example, or bus drivers, transportation staff, grocery workers, postal staff, food vendors, others, that a day without them is impossible for the social structure of society to function. These are essential workers that must go to work, do not have the luxury of being at home and working out of their laptops or smartphones, as they must go out into society and be exposed. They also happen to be very vulnerable populations in terms of having to work financially, as many are blue-collar workers and low-income workers. So when we talk about viruses and disparate health policies, we must be sure that two conditions are protected, in that disparate health policies can fracture opportunity, and it can also place certain community sectors at a considerable disadvantage. So let me conclude by emphasizing that for sound health policy and economic well-being to prosper, we cannot allow any segment of society to fracture or to fail. As such, high literacy in health policy is crucially important to understand and promote, as such policies bolster quality of life and economic well-being, as it also guarantees a healthy future for the country and its economy. So health literacy on the part of the provider is extremely important, not just on the part of the individual consumer or the individual patient. And with that, I conclude the presentation. Sorry that I ran a little bit longer than expected. And so I want to now leave it up to a Q&A process. And Dr. Leon, back to you.
Thank you, Dr. Novoa Rios, for this outstanding presentation and the great examples that you provided. Thank you so much. We've learned a lot, and it's time to see whether we have some questions. But before we get into the Q&A, remember that our next session is next Friday, May 15th at 1 p.m. So if you have any questions for Dr. Novoa Rios, please either type your questions in the chat box, or if you would like to ask the question personally and verbally, just use the raise hand icon and your line will be unmuted.
Dr. Leon, so we have one question.
Okay.
And let me see. And the question says, is there any language available in reference on trustworthy and non-trustworthy sources related to COVID-19? Or I guess maybe they're asking for any recommendations.
Dr. Leon, you want to take a stab at that?
All right. Yes. Sorry, Fide, can you just repeat the question?
Sure. Is there any language available in reference to trustworthy and non-trustworthy sources to read in reference to COVID-19?
You know, there are some federal organizations that are working on some resources for different minorities in the United States. I would recommend the Centers for Disease Control and Prevention. They have resources in other languages that are resources that you can trust. The information that is in the documents or fact sheets or infographics have been revised by experts. So those are very good resources, as well as a web page, which is covid19.org. Those are excellent resources to check for materials in other languages. And make sure that if you are looking for information that is trustworthy or information that is real, you have to go to sites like .org, .edu, or .gov, because those are generally institutions that are serious institutions and provide excellent information and information that have been revised by subject matter experts. Any other advice, Dr. Novoa Rios?
I would echo what you're saying. I would also recommend particular institutions like the American Medical Association and what they're putting out on an almost daily basis, the AMA. The American Nurses Association is also doing similarly. There are a number of articles that have also come out that are extremely useful and helpful. And rather than repeat a number of them, what we might want to consider, Dr. Leon, is to maybe do a short biblio quickly of some of this material and or reference sources, that is, and send out to the participants or make available in some way to all those within in this webinar, because I think that that's very important, especially in the context of much of the misinformation that is coming out politically or non-politically, from radio shows, from TV shows, and so forth. And so it's very hard to understand what is real, what is not. And it can be very confusing. And so I think that we can add value to that process and put it into a more medical perspective.
Excellent. I agree with you, Dr. Nova Rios. We're going to work with the team and see if we can put something together and send it to the participants. Any other questions in the queue today?
Not at the moment.
All right, I believe that we are over the hour. So once again, I would like to thank Dr. Nova Rios for this outstanding presentation. And to the audience, please complete the post survey. And if you need additional information on special populations and specifically information on public housing residents, please visit our website. You will find different resources and training and materials. Also, you can contact our staff. And if you have any technical assistance needs, please contact any of the staffs or go to our website and use the training and technical assistance feature, and we will get back to you in the next 48 hours. So once again, thank you so much for attending this webinar and this learning collaborative. We hope to see you in a couple of weeks. Thank you. Have a great afternoon.